we will be talking on treatment of medical management of ulcerative colitis, that is proctitis and proctosigmoiditis. So let's start our discussion. So for treatment of either proctitis or proctosigmoiditis, we initially start with topical mesalamine. Topical mesalamine. Topical means topical formulations are available in either suppository, enema formulation and foam formulations. Okay. So what is the difference between them is that for disease limited to within 18 centimeter of anal valve, suppository can work. But if it is extending beyond 18 centimeter from anal valve, this giving topical suppository may not be sufficient to treat that. Okay, so you have to give either enema or foam. Foam reaches up to mid-sigmoid colon and enema reaches up to splenic flexure. So depending upon the extent of disease, based on colonoscopy finding, you can choose between these topical formulations. So we in suppository we start with 1 gram mesalamine suppository at bedtime. Okay, and we assess the symptom improvement in 2 weeks. So we ask a patient, what is your stooling frequency now after 2 weeks of using topical mesalamine, whether the blood in stool has decreased or not, or whether it has disappeared. Okay, if patient is not having symptom improvement, then we increase the dose BD. We initially we are giving only night time, but if symptom is not improving, then give that topical mesalamine 2 times a day, 2 times in 24 hours. And if suppose if symptom is improved, then whether to continue the topical mesalamine for long term for maintenance of remission depends upon multiple factors, like let's suppose it is involvement of sigmoid as well, in addition to proctosigmoiditis that we call. Then in that case we have to consider maintaining maintenance therapy. If the relapse of flare occurs more than 1 times per year, in 12 months if there is more than 1 relapse, okay, in that cases you have to consider maintaining therapy with topical mesalamine. Otherwise you can discontinue and you can again restart when flare occurs. So if not responding in 2 weeks, then we increase to BD dose. Let's suppose if not symptom not improving even after 2 weeks of BD dose, then what we can do is one time you can give topical mesalamine 1 gram suppository, and another time you can give topical hydrocortisone. This is glucocorticoid. Topical hydrocortisone you can give 25 to 30 mg. Okay, so 1 time mesalamine and 1 time topical hydrocortisone. Let's suppose you prescribed this topical mesalamine 1 time and 1 time hydrocortisone, and after 2 weeks you assessed symptoms. 2 weeks you assessed symptoms. If it is again not improving, then in that case what you can do is you can add oral mesalamine in addition to topical formulations. So we don't discontinue topical, we continue topical. Okay, and in addition we add oral mesalamine. Okay, so what is the dose of oral mesalamine? Some clinicians use 2 to 3 gram per day. This is the standard dose. Okay, but what we do in our practice is more than 3 gram per day. This is called high dose mesalamine, because in our practice we have found that with high dose mesalamine patient have induction remission, high induction remission. That's why we give high dose oral mesalamine more than 3 gram per day. If even after with oral mesalamine patient is not having symptomatic improvement, then what we can think or what we can prescribe is Budesonide multimatrix tablet. Budesonide multimatrix tablet. This is oral tablet, and this multimatrix means this is maximum action on colon after reaching colon. When you take it through GI tract, it does not have much systemic adverse, much gastric effects, and it reaches to colon, and here it is local action, that it is available in multimatrix formulation. If not available, then you can start oral prednisolone. Okay, prednisolone. You start with 40 mg per day, 40 mg per day tablet. Okay, and regarding how much dose to give for how long time, this also depends upon the clinician preference, patient preference, and depending upon the circumstances. Generally, we can give 40 mg per day for about 1 week, and then we can consider tapering in the order of 5 mg, 10 mg again decrease. Okay, but some clinicians, what we have seen, that give 40 mg per day for 4 weeks and then consider tapering. Okay, but don't give oral steroid, okay, for a long time. Even topical steroid, what we suggest, that limit to less than 8 weeks, because that also has chance of systemic effects. So don't give for long term steroid. Okay, if and you have to assess whether patient is steroid refractory or not, whether patient is steroid dependent or not. Some patient, if you give steroid, patient has remission of symptoms. Okay, and but when you withdraw the glucocorticoids, within 3 months patient again have recurrence of symptoms. That is called glucocorticoid dependent, steroid dependent ulcerative colitis. Okay, or when you can't taper the prednisolone dose to less than 10 mg per day, when you start tapering to less than 10 mg per day, patient again have recurrence of symptoms, then that is also called steroid dependent ulcerative colitis. And in those cases you have to consider adding biological agents. And what is steroid refractory ulcerative colitis? Steroid refractory ulcerative colitis. So generally, after prescribing oral steroid, oral prednisolone, within 1 to 2 weeks patients start showing symptomatic clinical improvement. But if patient is not displaying symptomatic improvement even after 2 weeks of oral prednisolone 40 mg, then you can think that it is steroid refractory ulcerative colitis, and in that case you have to consider other biological agents and other immunosuppressant agents. Okay, so let's summarize so far what we have discussed about treatment. So what I told you initially, you start with topical mesalamine suppository, 1 gram suppository at bedtime. Okay, if not responding in 2 weeks, then you can increase the BD dose. If not responding, you can give one time, you can give hydrocortisone suppository, and another time you can give mesalamine suppository. If not responding to this, you can add oral mesalamine on top of the topical preparations. If not responding in 2 weeks, then you can give Budesonide oral steroid, Budesonide multimatrix tablet, or oral prednisolone. Start with 40 mg per day. Okay, and even with 40 mg per day prednisolone, patient is not having symptomatic clinical improvement, then you can consider this may be having, patient may be having steroid refractory ulcerative colitis, and you have to consider adding biologicals. Regarding biologicals, we will discuss in next lecture.